Move on to Dr. Rashmi DESHMUKH, who's going to talk to us about Xenia implants, the next generation in ocular implants.
So Rashmi is working in the cornea department at LV Prasad Eye Institute, and she has done fantastic work on Xenia implants. Let's see what she has for us. This is for keratoconus, I guess.
If Dr. Ashish is here, he can be ready, but yeah, thanks.
Yeah. At the outset, I would like to thank Dr. Rohit sir and Pooja for involving me in this session. So I'm going to be talking about Xenia implants, which are the new ocular implants used in advanced keratoconus. So traditionally, the management of keratoconus includes looking at the pachymetry. If the pachymetry is more than 400 microns, then we go ahead with cross-linking to halt the progression of keratoconus. And sometimes we combine it with intracorneal ring segments or PRK to regularize the cornea to manage the vision. But when the keratoconus is more advanced, then we either go for contact lenses in case the vision is not improving, then we go ahead with keratoplasty. And that is where volume addition techniques are in play now and are being explored. So human lenticules and including smile lenticules and donor corneal lenticules have been explored for stromal addition keratoplasty in keratoconus. However, there is a global shortage of donor corneas, and this was more prominent during the pandemics when it was difficult to get human donor corneas. A global survey in 2012 also showed that more than half of the world's population has no access to corneal transplant tissue at the moment, and for almost every 70 needed corneas, only one is available. So that is where the role of xenotransplants comes into play. And why looking at porcine collagen corneas is because porcine corneas are anatomically and physiologically most similar to human cornea. And there's a Bowman's layer also, so it is biomechanically as strong as a human cornea would be, as opposed to rabbit corneas where Bowman's layer is absent. Then what is Xenia lenticule? So Xenia lenticule is one such implant for xenotransplantation which is made of porcine collagen. It is derived from the anterior corneal stroma using a 4-step process. And essentially it is free of cells and any antigenic remnants, so it makes the chances of rejection a little lower. This implant is, once it is derived from the anterior porcine cornea, it is further cross-linked with ultraviolet light multiple times to make it a hyper-cross-linked and a stiff lenticule. Currently it is available in 90 to 100 microns thickness and in a 7 to 8 millimeters diameter in a disc fashion. So these were the 4 steps. Initially, the porcine corneal collagen lenticule is derived, then it is decellularized, and all the keratocytes and epitopes and antigens are washed away. Once you have the purified corneal extracellular matrix, then it undergoes collagen cross-linking to improve the biomechanical stiffness. The way it is inserted is that a femtosecond laser-assisted stromal pocket is created, and then the lenticule is inserted into the pocket and then unfolded and centered. So this was a part of a multi-center prospective open-label clinical trial. Sample size of 8 was sufficient to achieve the endpoints at our center. So we included all the patients more than 18 years of age with advanced keratoconus who were not suitable for collagen cross-linking, central corneal thickness of more than 350 microns, and contact lens intolerant patients were chosen. Patients with previous ocular surgeries, corneal scars, neurotrophic corneas, and having poor ocular surface were excluded. Also, corneal thickness less than 350 microns, and patients who were pregnant and lactating mothers were also excluded. So all the patients were subjected to slit lamp evaluation, corneal topography, confocal microscopy, and corneal OCT to look at the position of the implant. This is one of the examples of an OCT image of the implant placed in the anterior stroma. This was placed at 140 microns in a femtosecond laser-assisted stromal pocket. And this is the significant flattening that we were observing. This is over a period of 1 year. These are the slit lamp images where we see that at 1 month post-op, the lenticule is nice and clear. Towards more than 6 months, we can see that the central part of the cornea is clear, but there's a slight amount of haze towards the periphery which starts to appear. but the central cornea is clear. Looking at the results, the uncorrected and the best corrected visual acuity was statistically improved at 1 year. Even the keratometric flattening was significant at 6 months as well as 1 year. We could see a significant increase in pachymetry, and anterior corneal astigmatism also reduced at 1 year. We did not see a significant change in the posterior corneal astigmatism, but that could be because the implant itself was placed in the anterior cornea and did not have a significant effect on the posterior corneal curvature. We were able to recently publish this in the Journal of Refractive Surgery, these results. And like we see that we started with 9 patients, but we ended up following up only 7 patients at 1 year. This was because in 2 patients we had adverse events where we saw that just anterior to the lenticule, the anterior corneal stroma had melt. And we had to explant these lenticules. Looking at the figure of the histopathological image, we saw that the lenticules were still acellular when we removed them. There was no immigration of the keratocytes or corneal nerve fiber plexus within the lenticule. So similar experience was reported by another group of authors where they also saw early sterile keratolysis as a complication of porcine implants. The hypothesis that was suggested was that it could be an immune response to the implant or a response to the toxic compounds which are used in the decellularization or the chemical cross-linking process. During our discussions with the biomedical team of the company, we also came up with a hypothesis that there could be a mechanical stress exerted by this implant because it's quite stiff. So there could be a mismatch of the stiffness of the decellularized reticule and the recipient keratoconic cornea. So based on that, we decided to go a little deeper, and this is the follow-up result up to 3 months, when the lenticules are now being implanted at 220 to 240 microns depth. We are seeing that the uncorrected and the best corrected visual acuity is improved at 1 month, but it is not statistically significant at 3 months. Keratometric flattening is continuing to improve. We are seeing an improvement in the corneal pachymetry, but again, astigmatism was significantly improved at 1 month, not at 3 months. We are still following up these patients, and we are still trying to see whether they are continuing to improve or if there is any haze in the interface or if there are any stromal melts. This is the OCT image of a patient where the implant is placed a little deeper. And this is how the interface is looking at 3 months. Again, the central cornea is clear, but we can see that there's a slight amount of haze towards the periphery. So to summarize, porcine collagen implants do successfully improve the visual outcomes in these patients. These are cross-linked lenticules and supposed to have better biomechanics. They cause improvement in corneal curvature and are good for volume replacement as well, and could prove to be a novel alternative to human corneal tissue. But the technique still needs to be refined further to make the implant more biocompatible and to see why these adverse events were occurring in these particular patients. Thank you.
Thank you, Dr. Rashmi.
Thank you, Rashmi. Very nice innovation to use porcine instead of the human. I had a question for the 2 patients in which you saw the melt. Did you have any other surface-related issues? We know VKC is very closely related to, progressive keratoconus. So do you think that could have been one of the reasons?
So patients with any kind of ocular surface disorders were not included in this series at all. All these patients had healthy ocular surface to begin with. And the interesting thing that we were seeing was that all both the patients who had sterile melts, they appeared after 3 months. So before that, the ocular surface and everything was fine. Patients were still on topical steroids. But after around 3 months is when we are seeing the melt, and it is just anterior to the cornea. So we were, to the lenticule, I mean. We were also thinking whether it is affecting the nutrition above the lenticule of the corneal stroma. That could be one of the hypotheses that we were coming about. No history of severe eye rubbing, no history of allergic conjunctivitis. Sorry? We have not done any systemic evaluation of these patients to exclude any medical associations. We don't routinely do that, but yeah, might have a role.
Atopic dermatitis, ichthyosis.
Yeah, we don't routinely screen for Ehlers-Danlos loss unless we are seeing other features. Same with mitral valve prolapse as well.
Did you exclude osteogenesis imperfecta?
No, we didn't see any features to exclude osteogenesis imperfecta.
I don't mean that. Whenever you have got a keratoconus patients.
Yeah.
Keratoconjunctiva, VKH, and retinal pigmentosa are important. Severe rubbing is a very important cause.
Yes.
And sprinkler. The thing is that you have to see the genetic also. The families have to be actually, close relations have to also screen for keratoconus. Number 2. I have seen a case when I was in the Middle East. There is a case of achondroplasia associated with bilateral keratoconus. Achondroplasia associated with bilateral keratoconus. Reported in Saudi Medical Journal, a very rare case. These patients are short, frontal bossing, normal intelligence and bilateral keratoconus. One case in the literature, probably in the Middle East, has been reported.
Yes, thankfully we didn't have any of those kind of systemic features in our patients, but thank you.
Rashmi, one question. Do you see a difference in the visual outcome between cones which are central and decentered cone? And do you kind of, you just center the implant based on the center of the cornea, or do you make a change in the,
So centering the implant on the cone was one of the things that we are looking at in the future series. But when the multicentric trial started, it was supposed to be implanted on the pupil center only. So this result that I'm showing is based on central cornea. It is not centered on the cone. But at the same time, among all those patients that we have done, only one had a decentered cone and rest of them had central cones only. This was just by chance. This was not that we had selected those kind of patients.
So would you like to change your inclusion criteria in the future based on whether cone is central or decentered? Or
in the future, the thing that we want to try is, does it make a difference when you are actually centering it on the cone instead of on the central cornea? And then looking at those results, we would see whether we want to change the procedure or not.
Yeah,
Thank you, Dr. Rashmi.
Thank you.
Dr. Rashmi, just a few questions, just one or two questions.
Yeah, hi, Dr.
Would you still go with xenografts rather than smile grafts?
I would say at the moment it still needs to be improvised further, because until we find out why these adverse events are happening, we should not directly go ahead and start implanting it in every case. And we are implanting smile lenticules also in advanced keratoconus. Till now we are not seeing those kind of medicine using human lenticules, so we are continuing to do that.
Is it your preferred choice now to put deeper?
Sorry?
At a deeper layer, you said no 240 microns.
So we have only 3 months follow-up at the moment. I think longer follow-up is required because we've recently started putting it deeper.
And you don't have any cases which has progressed to...
Or they have
new
not
kind-
progressed,
none of them, yeah.
thankfully. Thank you.
Thank you.